Professor Matti Aapro, thank you very much indeed for talking to ecancertv. We're very concerned about the issues of old age. I have my 35-year badge on for ASCO, so I'm in that category myself. And the question is, if you've got patients with common cancers in the elderly, like lymphomas, chronic lymphocytic leukemia, that sort of thing, but it's the same for prostate or whatever. But what are your guidelines? Because you've worked in geriatric oncology and you're a big expert. How do you approach the position of age?
Gordon, I think that one of the biggest mistakes that we can do is ask the patient's age. It doesn't matter whether you have been a member of 35 years, 25 years. It depends on who you are. It depends whether you have comorbidities. It depends whether you have had a past history of treatment, which means that your bone marrow will already have been touched by chemotherapy, will not be as resistant to the new chemotherapies. The age by itself, if you go beyond 80 years old, it starts to play a role because it hides things we cannot calculate very easily. But up to that age, it seems that it really doesn't play really any major influence. It's really who you are, what are the other diseases that you might have that will influence your tolerance to treatment and also your prognosis. Because you might very well die from your myocardial infarction rather than from your cancer. So it might be futile to give adjuvant treatment. You already have a history of 3 MIs and there's nothing the cardiologist can do about it.
Yeah. Are there sort of screening rules for people, let's say over the age of 70, before you give chemotherapy?
I think that
baseline things you would want to do?
Baseline things that we would like to do have not been well codified until now, but it seems that it's important, very, very important, to look at creatinine clearance. Wow. One of the big mistakes we have done in the past has been to look at creatinine value in the serum, which doesn't reflect kidney function at all. We have to look at creatinine clearance. We can calculate for that. Yeah. There's a big debate nowadays whether you use one formula or the other. MDRD seems to be the formula that people like. But there's a debate which is the best formula. But we can use this formula, and they will give us very good guidance. Besides that, it's important to look at the patient's nutritional status. Albumin levels seem to be quite important, but we don't really know yet for which drugs they are important.
Yeah. And oral versus IV chemotherapy?
The issue with oral chemotherapy can be that elderly patients, like many patients anyway, will tend to forget to take the treatment. Will forget how to take the treatment. IV, at least you are certain of what you have given. On the other hand, it's the hassle of coming to the cancer center for the treatment. So it depends on who the patient is. And another caveat about oral treatment is that some elderly patients, especially above the age of 80, might have decreased gastric acidity, and that could change the uptake of some drugs.
Okay. But you're quite happy with fairly aggressive treatment, provided functional things are okay, baseline creatinine clearance. Okay.
The data we have shows that patients who are fit will benefit from standard chemotherapies. Again, it depends on which setting we are working. It's very important to realize that if you have advanced disease that is really going to kill you, your thing is going to be different from applying somewhat aggressive adjuvant chemotherapy for colon cancer or breast cancer in someone who might be dying from something else. So the way of thinking is quite different. But the most important thing for the elderly, the real elderly patients, is that we take into account the fact that some of our treatments can transform an independent elderly person into someone who starts to depend on the environment, on everyone around them, and that can be a social disaster. So we have to be very careful in our choices, because you can treat someone from cancer, prolong their life for a few months, but transform them someone who was happy and independent to someone who has to be in a home for elderly, very unhappy. So I don't know whether that patient will be actually thanking us for that.
And withholding treatment is not an option, if assuming the patient's fit and is compliant and agrees that they want treatment.
There's no reason whatsoever to withhold treatment from a patient who accepts the risk of some side effects, as in a younger patient. Some elderly patients will say, look, if this treatment has this amount of potential side effects, it's not going to cure me, and you can tell me that you're going to help me so that I don't die with pain and breathless or something like that. I don't want this. I don't need a few months more. So we have to respect that.
Yeah. Matti, thank you very much indeed.
You're welcome.